take a look at by another sociologist, anthropologist, Drugs for Life by Joseph Dumet, How Pharmaceutical Companies Define Our Health, in which he looks at the post-war era and the emergence of all these kind of epistemic practices that are foundational, bedrock to contemporary biomedicine, right? Long-term clinical studies of natural history, clinical trials, clinical epidemiology, pharmacoeconomic studies, that are really important ways of basically measuring the impact that new therapies can have on not just individuals, but on populations. And he says that this is able to help kind of construct a transformation in the way we think of disease as and treatment, not just treating felt illness, right? I'm feeling sick, I'm gonna go and get a drug, but that health systems are gonna be able to use treatment to treat a statistical illness, right? And by being able to treat a population, they can be able to garner some kind of economic value of this kind of future health, right? In hepatitis C, it's this idea of averted healthcare costs in the future, averted liver transplants, things like that. And these are actually really important practices about how we allocate capital. There's a deep rationality embedded in this that I argue is a really important part of what we do in thinking about how we allocate resources in society. But what I think is actually really interesting is ways in which this gets appropriated by the pharmaceutical sector, and particularly Gilead in this argument, and struggle over Hep C. So kind of walk through this kind of Wall Street corporate academia nexus and the construction of this common sense view. So as the company's facing a lot of resistance, Gilead's executives communicate to Wall Street, we've got all these publications out there, not by Gilead, but by respected people in the field who can start these conversations in a more of an academic collegial way. And their their R&D executive says, we're putting all of this together into a bigger pharmacoeconomic argument. And so just a few months later in the Harvard Business Review, you have prominent health economists from USC, from Harvard, citing their industry conflicts of interest, making the argument that actually this whole focus on price is just theater, and that society should kind of ignore all this kind of political consternation over pricing and pay up, because this is value for money. And ProPublica later actually does an analysis of how the pharmaceutical industry ends up enlisting a whole group of professors to justify these prices. And so I think it's an interesting kind of case study in the ways in which academia and health policy and the intersections with kind of how financial logics kind of come into health policy debates and then affect public health policy, right? So this is the National Academy of Medicine. We have a group convened to look at the elimination of hepatitis C. And they conclude from a medical perspective, we could eliminate it as a country, but from an economic perspective, the group concludes it would require near universal access to treatment, something that appears unfeasible given the current pricing and policy environment, right? This is 2016. 7 years later, in 2013, June of 2013, just a few months ago, the CDC puts out this headline. This is still where we're at as a country. Even though the prices have actually come down, and we can talk about that, the breakthrough cures for hepatitis C still fail to reach the vast majority of Americans who need them. Between 2018 and 2020, 15,000 people died of hepatitis C each year, right, from an avoidable cause because we have the curative treatment. Now, I can't say that pricing is the only driver here. There's a couple of other pieces to this puzzle, but it's one of them, particularly for Medicaid and patients that are in state prison systems that can't afford even the lower price of the drug. So what I argue in the book is that value in this case actually becomes untethered from ideas around maximizing access and public health, and it's completely fastened to financial markets and strategies of growth, speculation, and extraction. I'm just gonna put a finer point on it because Gilead actually gets swallowed up in all of this too, right? Because what happens with a curative asset? It's not a lifelong treatment. It can't generate the growth you need. So the company initially, stock price goes up, but as the Wall Street gets a handle on the fact that this won't generate long-term growth because it's not a lifelong treatment, their stock price actually halves, right? Even though they're making profit margins well over 40% and have revenues well over $30 billion. And Goldman Sachs says the quiet part out loud, right? Is curing patients a sustainable business model? Citing Gilead as their case study, right? And this is, I would argue, if you want to understand this headline, you have to understand what I've described up until this point in terms of financialized business model. This kind of concludes the empirical part of the talk. Just to summarize the three analytical frames, and I think that they're applicable to areas not just in biomedical innovation, right? I put in knowledge as financial assets. What about healthcare delivery entities as financial assets, right? And ways in which ownership and control operates and the implications of this. Value is talked about in so many parts of health policy, but how is it being actually configured in ways that actually are oriented around maximizing shareholder value, even if that's not made explicit? And then third, this idea of power as kind of hegemony, the ways in which these views become the common sense view in health policy and public health circles in ways that actually makes it really hard to kind of think about creating change. So in this last part of this talk, I'm going to describe a couple potential futures in this time of financialization. We know that launch prices for new treatments have gone up each year since 2008. This was a study from the Portal Group at Harvard looking at the trends from 2008 to 2021. You can see the numbers right there. This is just a headline from Sunday in Bloomberg Business. How is the country going to pay for million-dollar cures for gene therapies for sickle cell, for example? And the headline here is, we'll test whether the US healthcare system can afford to deliver miracles for the many and not just the few. And all these dynamics I've just described with hepatitis C, I fear will be replicated with the sickle cell treatments. And there are some that actually argue, to respond to this, we should double down on financialization. So this is a paper in Science in 2016 from a group at MIT that argues one way of doing this is actually creating new financial products, mortgages, to pay for curative treatments. In this case, insurance companies would pay a down payment, and then individual patients would have annual payments with an interest rate of about 9% to add to the list of debts that American households already have. The article does argue, however, to their credit, that a law mandating full coverage for curative therapies, allowing for price negotiation, would likely be more economically efficient, sustainable, and socially more acceptable than a pure private sector solution. And we actually have a great example of this straight from hepatitis C. It's called the VA. The VA system, after an initial period where they struggle in terms of figuring out access, once they figure it out in about 2014, the red line is the curve looking at the number of patients, veterans awaiting treatment, plummets because they're able to diagnose and treat people because they have negotiated prices, universal access, and the VA health system is on a path to eliminate hep C amongst veterans. And in an equitable way, all the subgroups across veterans have a greater than 80% rate of being treated, right? So this is like health equity in action here in the case of hepatitis C through the VA system. And there's other bright spots. Louisiana, they try something called a Netflix arrangement, where basically the state agrees to give a lump sum payment to the pharmaceutical sector in return for unlimited access to these treatments for a defined period of time. And this is a win-win because the companies get some guaranteed revenue, and it incentivizes the health system to go out and diagnose and treat as many people as possible. And this idea is being talked about, being scaled up at a national level. So Francis Collins has proposed this. This was a piece in JAMA, to create a federal Netflix program that would basically procure these drugs for all the state Medicaid programs, state prison systems, Indian health services, all the systems that don't have the money to pay for these drugs at their current prices. So we'll see where this goes. And there are bigger ideas outside of hepatitis C, but just how we think about the public sector in the innovation process altogether, and whether we should be thinking about more public options, right, around research and development and even manufacturing. So this is a paper, this is a white paper by the Democracy Collaborative that analyzes the public options that the public sector can take in R&D. And so this, there's discussion around this new agency in the federal government that Biden has started called ARPA-H, Advanced Research Projects Agencies for Health, whether this could be an agency that is involved in the late stages of innovation, and when they are, actually set fair pricing and access provisions when they work with the public sector. Operation Warp Speed is an example of the government actually being really involved in the late stages of research and development and helping develop the COVID vaccines. And then in California, Governor Newsom has put $150 million behind creating a public manufacturing strategy around insulin, partnering with a nonprofit group, Civica RX, to try and see if the state can bring down the price and cost of the overall health system as well as individuals in the case of insulin. So I'm just gonna come back to where I started and hepatitis C. these ideas that I just talked about, they're important so that we don't keep on repeating what happened with Hep C, right? Where there's a curative treatment, patients are waiting, and in the clinic, this is just what the health workers had to create. There were all these post-its, right, up on the clinic walls, trying to figure out how to work through all the paperwork to try and get even those patients with advanced stages of Hep C access to the medicines. And I think part of this work is just to argue that we shouldn't take this as the status quo, as just the taken for granted natural way that we do biomedical innovation and access to medicines. That part of the work has to be to denaturalize this, to defamiliarize ourselves of this kind of phenomenon, and to have a kind of imagination about how things could work otherwise. So I'll just end with a little bit of an inspiring quote from an author, Ursula Le Guin. The exercise of imagination is dangerous to those who profit from the way things are because it has the power to show the way things are is not permanent, not universal, and not necessary. Thank you so much. So I'm happy to have, hopefully that provoked a lot of thoughts. And I'm happy to kind of have a conversation and back and forth.
Yeah, so in a second, I'll open this up to questions, but I just want to commend Victor on really a stunning analysis on an area of scholarly research that has really not garnered the critical attention it deserves. So I'm super grateful for this work, and yeah, I'd be eager to hear what people think and the questions they have.
Maybe some, yeah.
This is a question, although it may sound like a rhetorical question. I honestly don't understand why people are bothered by the stock buyout thing. I understand if insiders are buying the stock, there's a question of whether they may be getting other shareholders to overpay if they have inside information or whatever. But why are people so concerned about stock buybacks? It just seems to me like we have a capital market, and we have shareholders who want to sell shares, and we have other people who think the shares are worth a lot. I don't quite understand why there's such a public outcry over that particular mechanism, and what it demonstrates.
I think it's a good question. So I think that there's kind of two ways at looking at kind of share buybacks. I think one, there's actually just a fundamental framing question, right? That if corporations on the one hand are actually telling the public that we need to charge high prices because it costs a lot of money to do business, but on the other hand, they're actually saying we don't have uses of this capital and we're going to just drive this into share buybacks. There's actually fundamental, I think, tension and contradiction between those two arguments. And so it's not so much the argument is here, let's stop share buybacks. It's the fact that these companies have this amount of capital, right, to work with, indicates that maybe actually more systems in which we have more competition, price regulations, regulating some of these companies as public utilities wouldn't be actually a bad thing, and that all this money is being driven into share buybacks is less about kind of analyzing the share buybacks itself and tells us a little bit more about like where the market dynamics are and how companies are able to derive that amount of capital in the first place. There is a second point in that this does drive the incentives of the key actors in the firm, right? The executives. And so if your major part of your compensation packages are in stock compensation, then you're going to pursue strategies that can maximize the amount of capital you have to engage in share buybacks. So I think it's less about kind of trying to regulate share buybacks, but more what it tells us about the overall ecosystem and the arguments that are being made. Yeah.
Who can do things to manipulate the stock price. But that's not really about pharmaceutical companies. That's really just about how do we properly regulate the capital market so that people with inside corporate power can't in some way leverage those improperly. I'm just puzzled by it.
Victor, fantastic talk. Can you explain a little bit about how the maximizing shareholder value causes these executives to behave and price differently than just monopoly pricing? They have a patent, they can monopoly price. How are they behaving differently because of the financialization than just like the classic monopoly pricing of a firm?
So I think I think that's a great question. So I think the thing is that they're intertwined, and so and part of what's happening here is that over time, the strategies of the big publicly traded companies in this scenario of maximizing shareholder value. I think the key insight there is like the way that they become more oriented around acquisitions, right? And so the way, how do you engage in acquisitions? Most like that's driven primarily by driving huge cash stockpiles, right? That they can accumulate over time. So part of the idea here is that you use monopoly pricing to then generate major cash reserves that can be used to kind of drive a cycle of acquisitions and buybacks, right? Those are like the two major allocations of capital that these firm executives are kind of driven towards. And how this implicates price, like how does that influence like the actual prices? I think that's where you have to bring in the analysis of really it is about how the prices increase over time, right? And so these companies, it stacks it, right, over time. And so that's where you have companies that if you look at their cash reserves, 20 years ago, and this is an empirical question, but I'm going to hypothesize that the cash reserves were actually much smaller than they are now, where you have companies like Gilead at that time, I think had over $30 billion in just cash, right? And that's primarily driven by the fact that like Wall Street expected them. They couldn't, even if they wanted to, price it at like $30,000 because Wall Street was already anticipating that the price of the existing treatments are $70,000, $80,000. And so you have to, the idea is like the whole chain of speculative capital is, well, you're going to be able to make a little bit more if you come up with a better treatment.
So you're saying that like for Hep C drugs, they deviated from profit maximizing monopoly pricing because of this history of stacking. Like they might have made more money in the short term had they charged a lower price because of just the standard relationships between what Medicaid could afford to pay and the number of people that it could cover, right? Or do you think they extracted like maximum monopoly profits from the Hep C drugs? Or
I think that, so it's a complicated story that is kind of hard to unpick because the company anticipated that they only had about like 1 or 2 years before other actors would kind of enter the market. So they knew that in those 2 years, they kind of had, or in that period of time, they had kind of maximal control over the Hep C market. So in that time was the time where they could go as high as they could. And they tried to model out kind of what the upward limits are, right? That's part of the heat map I showed. And they assume that if they went any further, they'd even face even more consternation. So it's a and then yeah, so it's a bit of a complicated story, but that's kind of what the calculation was in that time period. That's a good question.
Going back to the first question, I guess maybe another way of framing it is if you feel that there's a different rule book for healthcare or pharmaceutical than there are in other capitalist industries. So I think, just, I mean, as a physician, like this, the idea, and we talked about this a little bit, like that capitalism being applied to healthcare, which is supposed to be about altruistic, saving patients' lives, it's a different sort of field. At least we view it that way within medicine, but it's certainly profitable for companies. So I guess like, how do you, is it maybe more about like rule book and how we look at what should be governing their practices?
Yeah, so I think one way, and this kind of, let me try and like go back to Harold Pollack's question about the share buybacks, and your question about the value. I think part of this is really a debate about who creates value and how and where that value goes, right? And also who takes risks, and how we allocate the rewards. And in healthcare and in health, a lot of the risk is borne by the public. If you look at research and development in biomedical research, if you look in the healthcare delivery, right, who covers low-income patients? Who covers elderly people that are more sick and are going to be harder to cover otherwise on insurance, right? It's public programs. And so I think, to your point, part of these things exist because we view health to be, in at least some places, a common good or a public good. And so then I think that in this kind of environment, when the public is so involved in trying to deliver that good, then it should invite certain kinds of questions about, do we have the relationship between the public and the private set up in the right way? Do we have risks and rewards shared and distributed in the right way? And I think that's what this book is trying to get at, is like, I think it's out of balance, because if we think it's in balance, then like what we've just described, it should be just like how we do it, right? Like this is the best we can do. And breakthrough treatments, we have breakthroughs, but really follow through. follow through, can take 10 or 15 years, and people that are low income on publicly funded programs, they'll get the treatment when they can get it, right? And like that's kind of the kind of deeper question here is like in a public-private system that we have in the US, is the partnership between the public and the private parasitic, or is it symbiotic? And so I think we can have that debate, but I think those are the kinds of questions we need to be asking.
So I think you made kind of a provocative analysis where you talk about power and hegemony, and you've kind of shined the spotlight back on us and the scholarly community, and particularly the health policy community, and the way that certain individuals or areas within health policy, the epistemic authority that they've gained has kind of informed the logic of what is value and how we should price our drugs. And I'm wondering from you, like, for those of us who are concerned about that logic within the health policy community, how do we start to untether that logic? How do we start to like question the underlying logics, and like what do we do to start complicating our certainly our complicity, our complicit nature within this issue, but also how do we get to the futures you're talking about?
Yeah, it's a great question. I'd say there's a bunch of different strategies. One is I do think that there are kind of solutions that are on the margins or might be on the margins of academia, some of the ones I just described. But actually, I think it's important to study those and try and figure out what empirical methods we can use to study some of the alternative mechanisms that are proposed, alternative models. I think that brings in fresh debates into the sphere. I think in terms of trying to diagnose and analyze the problem, I'd love to think about like how what kind of different research methods could be used. I use very non-traditional methods where I coded like earnings calls transcripts, right? Like they were much more informative to me than the interviews that I did with some of the insiders, because they're just saying all the things out loud, and it helps you understand actually what logic is at play here, rather than like kind of some answer you might get from an interview. And I think that, so we need to think about what are different research methodologies that can kind of get at some of these questions of political economy, the institutional dynamics, the historical dynamics, so that we don't start the conversation taking all the kind of existing dynamics of health policy as just a given. I think that's where we end up with a narrow discussion, because we assume all these kind of variables as taken for granted and as givens. And I think we can use some creative methods to empirically look at ways in which some of those assumptions could be unsettled. And I think I'm not sure if the NIH will fund that, but there are other funders, and I think other groups that are interested, particularly because people are trying to have some kind of like new economic thinking around some of these issues to kind of come up with some different ways at these questions and problems. I don't know if that answers your question, but yeah.
Hi, thank you for a great talk. So I'm curious in terms of thinking about policy and solutions, how the Inflation Reduction Act and like the Medicare drug price negotiations could possibly be part of a solution, and also with Medicaid being also, a mix of federal and state funding, how, thinking about policy where people who on Medicare maybe have access to a medication, but people on Medicaid are being denied the same medication, and just thinking about, policy in that regard and how that interacts with this conversation.
Yeah, I think what I'd say is that obviously what I've just brought up, there isn't like one magic bullet solution. There's like a whole set of policy options that are going to be applied and used for different treatment areas, therapies, because it depends on, is this a rare disease? Are we talking about large patient populations? There'll be different policy options for each of those things. I think the Inflation Reduction Act and what you're referring to with the introduction of drug pricing negotiation after a long period of struggle in US health policy circles to actually finally have that, even in a limited way, will be a really interesting kind of experiment to see how that actually goes. And it'll be with a limited set of treatments initially. I think the challenge is how do you actually move it? Right now, those negotiations can only start many years into after the drug has been launched. And I think part of the question is, can we learn enough from that experiment to then at some point be able to argue, especially for the treatments that have huge public health importance, to bring that up right into the negotiation process when they launch, right? Rather than just assume that it's going to be 7 years or 8 years until the public will be able to afford this treatment. I think those are, bigger policy questions that are, going to take years and decades, maybe. Well, hopefully not decades, but are going to be part of the political struggle. I think Medicaid is also obviously, a different beast in terms of how to think about that, because we've got 50 states with 50 Medicaid programs, and with very fragmented negotiating power. And so that's why I think this Netflix model is interesting with the Hep C. Like, can they actually do this where they kind of basically aggregate the negotiating power of all states and their Medicaid programs to say, we as the federal government can do something that you as an individual state can't do. I think that's why I think I'm watching this Hep C closely. Unfortunately, because of the political gridlock, we don't see movement on this, but at least as an idea that it's on the agenda, I think is promising, because maybe that could be one approach with some of these more breakthrough treatments.
Victor, good to see you.
Yeah.
I have two questions for you. One related to your last answer and sort of the end of the talk, and a second one related to the heat map. My first question is about like the futures in the gene therapies and the sickle cell disease that you mentioned. And my sense is that that's going to be far more expensive than Savasivir was, which was like, what, 84,000? And this will be probably add 2 zeros at the end of that.
Yep.
And my sense is like, what lessons do you think we can learn from Savasivir that can be applied to the far more expensive cases? Do you think that there are pair models that are like in place or could be put in place, like Netflix or other things that could be done? And then also sort of on the business side, like, do you think that the scale is going to change some of those conversations? Do you think you'll see those types of headlines that the Goldman Sachs people had? And then I guess my second question is on the heat map side. Like, you had mentioned that they had like mapped out the possibility that like Congress would be called in. And then, like, notoriously, Congress was called in for Savasivir, and they wrote an 80-plus page report about Savasivir and how bad it was and how it was a case study.
Yeah.
And, like, do you think that the companies have a sense of the public relations piece of it, if even anticipatorily they, like, thought that Congress might be called in and they were completely wrong? So I guess just to summarize, one about sort of the gene therapies and cost, and second about sort of the public relations aspect of things.
Yeah. So the gene therapies, I think, are, as you say, are going to make Hep C look quaint, right? Like, that was $90,000. We're talking about $2 million with what we're going to see with like the sickle cell treatments. It is a smaller group of patients, but still a much higher number per treatment. And so I've got, like, these are extra slides that I've got up, but I think that the lessons, unfortunately, are, I think what we're going to see is like a way in which unfortunately, with the sickle cell treatments, I think we're going to see race play, a really problematic role, in that the pharmaceutical sector is already trying to figure out how they can actually use an anti-racist frame to argue that actually, if we value Black health and Black life, then we should pay this much money for those treatments. And they've kind of, these are just some like examples where Vertex has given money to Ibram Kendi, and kind of like the framing around this, which is, going to be really an interesting argument. And actually, there are parallels with what happened in Hep C, which is that a lot of the folks were like, if you don't pay for this, then you're stigmatizing this structurally marginalized patient population, which is a really interesting kind of framework to kind of crack. And I think in terms of the headlines, I think we're going to see headlines around sickle cell. We already are, and once they come out, particularly with Medicaid programs. And I think there's been discussion around like outcome-based agreements, right? Where, companies, basically there'll be kind of like a bit of a pay for performance kind of agreements, but we know that those are really actually hard to enact in practice, and clawing back money, for example, if the treatments don't work. But I'm not an expert on those kinds of agreements. I think the Netflix agreement would seem to be something like that would also be really interesting to try out. But we'll kind of see where the policy discussion goes on that. I think we at least do have the Hep C example to like quick, if you want to get a case study, I would encourage people to read the book, because basically a lot of those things, I think you can probably replace the price and the treatment, and a lot of the dynamics will probably be pretty similar. So hopefully, we can advance the policy conversation pretty quickly. And then in terms of the public relations piece, Hep C is an interesting example, because I think the companies did anticipate some blowback, and particularly Gilead. Part of the challenge was that there were so many patients that they didn't anticipate would actually want the treatment right away, because they were kind of warehoused, as it was being called, right? Because these were patients waiting for these treatments. And so as soon as this treatment came out, there was a large number of patients that could benefit. And so the costs were so high that it did kind of create the sticker shock. And I think this is something that they underestimated. But at this point, I think this is part of where it's going to be interesting to see in the ways in which I think, arguments around value. I think the reason that the companies now don't want to talk about R&D costs, because there's no relationship, right? Like Gilead they made $46 billion. I guess they would argue that they spent $11 billion to buy the drug, but that's not an R&D cost, right? That's the cost of circulating finance capital through the process. And so that's why this value argument is going to be really powerful, I think, and what they're going to lean on to really kind of drive in these PR battles. And I think part of it is going to be about bringing in the key kind of academic voices to help them make those arguments.
Yeah, let me just
Yeah,
bring in a couple of questions
Yeah.
from people on Zoom. So one question was about whether the Netflix approach, whether it applies to only states' Medicaid programs, or should we be viewing this as like all for all payers? And then the other question, how do you think about incentives for firms to develop curative treatments? Is there a relationship to financialization and the development of more curative treatments?
Yeah, those are both really good questions. So the all-payer Netflix model, the idea for the Netflix model comes from a country that actually did it exactly that way, right? Like in Australia, they did a federal program where they basically are like, we're not going to let you guys enter our markets unless we strike a deal. So Australia is where we see this first kind of really take place, where they had about, I don't remember exactly the dollar figure, but a small amount of, small meaning like $1 billion or something like this for hepatitis C. And they went to the companies and struck a deal for a Netflix model, and it actually put the country on path to elimination. And so, I think that's just like much harder in the US system because we have so many fragmented actors and vested interests. And so, to try and get all pairs on that train is going to be a huge challenge. But I think, that should be part of the policy conversation. Because that would be even more powerful for the kind of our breakthrough treatments. Now the question of incentives, I think around curative treatments, it is really hard. I think the reason that these treatments were developed in part was because there was such a huge patient population, right? That like they did make a lot of money. So there was like a huge financial incentive in that way. But again, like the argument that then Gilead actually used that money to kind of drive towards cures for, let's say, HIV, if anything, it actually taught Gilead, and you can actually read the earnings calls transcripts, to tell Wall Street, like, look, we've got these HIV treatments. Guess what? They're lifelong treatments. And it's like where we're going to base our growth off of, right? Look at PrEP. We're kind of trying to get people on PrEP. All these treatments, these are lifelong treatments. This is where we're going to get growth from. And so it didn't actually necessarily incentivize, so to that question, I think it's a really challenging one. And I think it depends on the treatment we're looking at. I think I didn't answer I think this goes to Fraser, your question also around curative treatments. Like, I think it depends on the patient the size of the patient population that could benefit, the length of treatment that would be entailed in that given area. I think the idea that people have talked about for a long time is this delinkage model, right? Where the public offers prizes. And this has been in the policy conversation for a long time, where the government basically delinks the R&D market from the pricing and delivery market, where they go to a company and say, we'll give you $10 billion if you develop this drug, and then we're going to license it to to a generic manufacturer, for example, or to a manufacturer that will manufacture this at the cost, near the cost of production. That would be like kind of the easiest way theoretically to incentivize cures, where the public says there's a big public interest, we will allocate amount of money, we will give you a prize, and then we can then make it widely available at the cost of production. And I don't know if I mentioned this, like in this case in Hep C, the drugs only cost $100 to manufacture, right? The price at $90,000, but it costs about $100 in the factory to make.
Yeah, thank you so much for this insightful talk, Dr. Roy. I guess I'll just come out and say my question's about single payer. And I'm just wondering, like I think we've talked about some of these other possible options and ways that people are approaching this, like the Netflix model and things like that, but they're very like, fragmentary approaches. They might work in some places, not others. They benefit some people and not others. And so just thinking like, from a medical perspective, if our goal is to get people the treatments that are indicated, when they need them rather than delaying until they have end-stage liver disease, et cetera, how do you think like, a single payer model where you have this much stronger negotiating power on the side of, the payer, given that you said, like Medicaid is fragmented and like, thus less people are covered, like how would coverage and treatment of things like looking into the future, like these sickle cell treatments and then Hep C patients now, how might that look in a single payer model? And what are other possible, like, I don't know, side effects or unintended consequences that you might foresee?
Yeah, so I think from the Hep C example, we saw what happened with single payer across Europe, right? So what happened there, just kind of, and I'm not putting up the empirical evidence, it's in the book because I do cover some of what happens internationally in chapter 3. But what happens in those systems is that there are delays in terms of access of months to sometimes a small number of years, because that period of time, the single payer systems are negotiating with the industry. Like that's what that time goes to. Unlike in the US where like the treatments were available, but only to a fraction of the population, in the single payer systems, the access opened up a little bit later, but to a much larger, like, to most of the patient population pretty quickly. And so I think that's kind of one, we just have case studies of what happened during Hep C. And then, same thing with the Australia example, right? They were able to use their negotiating, like what we know of monopsony, right? The power of a single purchaser, not just a single producer, monopsony power of the government to be able to then negotiate prices in a way that, is more favorable in terms of access. I think, of course, there are huge political, fights around that because there will be the argument that we can talk about around, how does this change the incentives for doing R&D?
Yeah, so thank you for this talk. I had a question on the research and development for drugs with or diseases with very low patient populations. So is the actual money that's spent towards the research and development proportional to like the graph that you showed us earlier, where like a lot of it, 3 times the money was spent on shareholder value and like only a small portion was spent on research and development? So like for gene therapies, when they say that research and development costs are much higher, is more of that going towards shareholder value, or is it proportional to like how many people
It's
are
an
being-
interesting question in terms of I'd have to actually like empirically look at that in a way that was systematic that I didn't in this study. I think that because of the smaller patient numbers, there's the idea, the premise that you can, charge higher prices because that's the only way to kind of circulate the capital in a way that people will want to invest. And so I think that that's definitely a piece of this. And when there are smaller numbers, I think payers can deal with that a little bit easier, though I'm sure other people would maybe have counterpoints to that claim that I just made. I think it becomes much harder when there are multiple rare disease treatments like might exist in 10 years that are all like $3, $4, $5, $6 million. And then the population of rare diseases ends up being actually like not so rare because of in aggregate, it's actually quite a bit of money. So, I think that in this case, that is all about like how do we circulate that those prices. The premise behind the price is like what I've described is like how do you circulate enough capital to kind of like finance especially rare disease areas. Whether like companies that are doing this disproportionately spend their money on shareholder payouts versus R&D, I would venture a guess that the patterns are pretty similar, but that's an empirical question that I would need to take a closer look at.
So we're about at time, but I again want to thank you so much for this really exciting and fascinating talk. And this will be one of many talks on the financialization of health for this year. So I invite you to come, and I appreciate everyone who came here today. Thanks.